We get into today's episode, I was going to share one of those horrific getting old scenarios that played out yesterday. So I was trying to take Rem on a walk, and she has been on a walking hiatus with just one person since spring. And if you follow me on Instagram, we typically walk daily. And we had a really hard time with sound sensitivity a few years back. She turned one, and it was like someone flipped a switch. She was scared of everything. She stopped walking on leash. She was very skittish during storms and any loud noises. And so we did a lot of training and we overcame a ton. And for 4 years, we were going strong with our walks. With that being said, we would always navigate around bad weather. We are very cautious about what places we go. For instance, if we were to go downtown to a brewery, there are certain places that have like bus stops right outside, or like construction work. It's not going to go well. So we just avoid things that we know will trigger her fear and just create a bad experience. With that being said, we've been doing great. We literally train twice a day. Every meal is training, all of the things. In the spring, she stopped walking, but it seemed to be correlated with bad storms. So we assumed that once the storm season ended, we would kind of get back into our normal routine, and we just never really quite got there. I think over the summer I was able to get her out 3 times by myself, where she just kind of took off and go. So she's essentially made the decision that she's not walking with one person. With me and Nikki, she is happy as can be, tail so high up, she like can't even contain herself, because I know she like wants to do this, but she will not pass the grass of our house and turn the corner. It's actually quite frustrating and insane. So yesterday it seemed like she wanted to go, and she hadn't been on a walk in a while. So I was like, well, let's see if let's see if it happens. We walk out the door, looking good, make it down 3 steps, looking good, puts on the brakes, lays on her side. Like, she is a ton of bricks, and the only way to go, I would be dragging her on her side, which we've learned different techniques from the trainer, and they essentially tell you to keep walking, right? Apply pressure, keep walking. Well, you cannot do that when you're like dragging her. And even if you're trying to like get her out of it, you have people walking by. They're like, what's happening there? So it's 100% totally embarrassing, but it's not worth creating a worse experience. So she has been walking in the cul-de-sac for whatever reason. So I literally said to her, all right, let's check the mail. She pops up like she's ready to go, and she's walking the cul-de-sac like, confident as can be. As soon as we get to our house, puts on the brakes, wants to go inside. It is what it is. I only have so much strength to like overcome this. But she stopped at the car, and she likes to go for car rides. And I was like, you know what? Let's run to Starbucks. I haven't had a pumpkin spice latte, and it feels like fall. So it feels like the right time to do this. So I jumped in the car. It's only a few blocks away. So I order my basic pumpkin spice latte, and there's no one in front of me, right? So like there's not a line. There's literally, I order, I'm at the window. And as I'm approaching the window, I'm opening my swing pack, and I realized that I took my wallet out of my swing pack to put her treats in. No big deal. It's the world of technology. So I was like, just give me a second. I'm going to open up my Starbucks app, because you could pay off of that. I open the Starbucks app, and it has logged me out. Problem is, it's Nikki's account, and I don't have her password written down. So, Face ID is not working. I don't have the login. I don't have time to text her because I'm literally at the window. So I asked, do you take Apple Pay? They do, which is wonderful. It has literally saved me like 3 times in these random episodes. And all 3 times, I have no idea how I've gotten to the little scanny do to pay with Apple Pay. So I pull up my Apple wallet. I get to my Apple card. I can pay my card in this part of the app. I can do all sorts of things. I can give my credit card number if I needed to, but I don't have an instruction on how to actually pay with Apple Pay. And when you're like, I wasn't panicking, but I was like, starting to get there. Like the stress is rising. She's already handed me my damn coffee. I'm like, this is a stupid question. Do you know how to get to Apple Pay? She's like, yeah, just double click the button. And she pulls up her phone. She shows me which button to click. I'm like, oh, great. Okay. I do it. It locks me out. It literally closes out my phone. I'm like, it put me to the lock screen. So I'm like, oh, I must have just not got a double click. I do it again, locks me out again. She in like the most, calm Gen Z voice tells me, you just double click it twice like this. Boom, boom. Like, I understand what you're saying. I'm clicking the frickin' button. It's not happening. All right. So I'm like trying to not panic. I finally get the damn thing up with a double click after the seventh attempt. She hands me the little thing to scan. I face it down and nothing's happening. I'm like, here we go. Here we go. I like am showing my age right now. I can't freaking use Apple Pay. Every little scanner is different. Sometimes it's on the top, sometimes it's on the side, sometimes it's on the bottom. Well, apparently there was a question for adding a tip, which she didn't actually like show me. So I'm just holding it against the screen. She's like, just put it face down. I'm like, all right, here we are. Listen, in real life, I'm typically pretty technologically sound. Apparently, I cannot use Apple Pay. I can run my mother's computer in New Jersey from Kansas City. I can fix her printer across the country. I can't freaking use Apple Pay. So, needless to say, now I know how to do that. If anyone here is in the same predicament where you're like, I have no idea how to access Apple Pay. Literally, if you have an iPhone, you double click the button on the right side. And yes, if you don't click it twice good enough, it's going to lock your screen. Second piece of advice, if you don't have Apple Pay set up on your phone, it might be worth doing because it has literally saved me 3 different times when I've walked out of the house without a wallet. So there's my 2 cents on Apple Pay and technology. But I had one of those embarrassing, panicky moments, and I can just see Rem's in the back. She's like, you know what? This is ridiculous. Now you've just embarrassed all of us at this episode. So pumpkin spice latte was good. I was able to pay for it. I felt really old, and hopefully I have taught you something. If you did not know how to do that, and if you do, and you're judging me wholeheartedly, you're welcome for this conversation. All right. I wanted to jump into today's episode. I was actually going to go over a case. I've had some fun patients in the last few weeks that are not, and I'm using air quotes, cardiopulm patients who are very much cardiopulm patients. And one person in my mind really sticks out who was an ortho trauma case. So he's a 52-year-old male, status post motocycle crash. So he had a high-speed crash, and he has a number of injuries, considering, minor, but left-sided injuries nonetheless. So what do we got on our list? We have left scap fracture. We have left medial malleolar fracture, a left distal fib fracture. The distal fib fracture was reduced in the emergency department. They called it non-operative, but they were planning on fixating later. So he has a planned OR for the fibula in the future. He was in a cast or splint when we came in. He also had small left hemopneumothorax. He also had multiple left rib fractures from rib 3 to 7, and he had a mild pulmonary laceration of his left upper lobe. So this ortho trauma case that really is, left lower extremity non-weight bearing type case, he's now a true cardiopulm case. So he was non-weight bearing, left lower extremity. He was weight bearing as tolerated left upper extremity with that left scap fracture, but they wanted him in a sling. We needed some more confirmation on range of motion restriction or privileges, but we had not received that yet. So left upper is in a sling, but he's weight bearing as tolerated in theory. Left lower is non-weight bearing. 52 years old, acute care, ortho trauma case. When you have both arms involved, painful wise. Oh, and he also has road rash. He has 10% of his body is covered in road rash, primarily upper extremities. But I did not visualize chest as well. Actually, the burn team was finishing up when we were going in. So from an acute care perspective, right? Like this is that transfer case that you're trying to figure out what's going to be his best mode of independence moving forward. At this moment, he's either going to be a squat pivot transfer or a slide board transfer to his right. And pending range of motion, information for left upper, maybe would be able to progress something in the stand pivot, maybe short distance ambulation, but it really all depends on what they want for that left upper extremity scap fracture, if they're going to allow range of motion as tolerated, since they're allowing weight bearing as tolerated. So we didn't get clarification on that. So primary thing right now is, squat pivot versus slide board transfer. Great. He did wonderful. Popped right over. Didn't need the slide board. Was able to control it. Overall, considering he had high pain overnight, he was tolerating pretty well. But his primary complaint was pain in his left ribs, especially with deep breathing. And he was terrified to cough. I am so excited to teach you this thing. So, on paper, he does have some cardiopulm diagnostic things. He actually has a lung laceration. He has rib fractures, but big picture acute care, don't just get stuck on the ortho trauma transferring stuff or gait training stuff. He needed a ton of cueing. He was a fun cardiopulm assessment. And he did better, right? Once he had some cues. So from an assessment perspective, we did chest wall assessment, just watching his rib cage motion. I performed anterior upper and anterior lower. I did not assess posterior, but that's what I would do the next session, especially with scap involvement. Had decent diaphragm excursion, but I didn't want to test via the sniff technique because that would increase pain to left ribs and potentially lose some of that, rapport and trust in what we were going to do next. Auscultation diminished left side compared to right. Otherwise, good breath sounds, clear, but left side super diminished. On assessment, he had minimal excursion, left lateral, lower, as well as upper, just very guarded. All of his movement was to the right for the most of it. So primary thing that we did was lateral costal breathing and segmental breathing. So in the beginning, I just had both hands on his chest, and I talked him into what that would look like, and just explaining that my hand is just going to be placed here, and to think about my hand placement. So I kept it lateral costal, both sides, to allow him to take a big breath and expand bilaterally. Once we were starting to get motion on both sides, and again, no overpressure on the left because we have multiple active fractures, I switched just to segmental breathing. And so I had flat hand along the lateral, 3, 4, 5, 6, 7. I kind of adjusted as we went. And primary concentration was just breathing into that hand. Full concentration, calm breathing. Once he was getting more excursion, we moved into inspiratory holds with segmental breathing. So I had him inhale, hold, long, slow exhale out. We started super low, 1 to 2, build the trust, 1 to 2. We got as far as 2 to 4, and I left it there because he was getting good movement and he was not in extraordinary pain. Before we actually moved into lateral costal breathing, segmental breathing, I had him do incentive spirometer just to see his effort. His effort was pretty good, but he didn't get a lot of motion, and his his inhale attempt wasn't very long. After we did lateral costal breathing, segmental breathing, he was able to increase up to, I believe we were at 750 to start, and he went up to 1500 post. So just a little bit of cueing allowed him to take a bigger inhale. Post breathing exercises, left side had better air movement. Was it equal? No, it was still diminished, upper and lower, but it was more than the start. So pre and post assessment can be super helpful with auscultation and or incentive spirometer, and you can show that pre-post. We also practiced coughing. So he has multiple rib fractures. They were non-displaced. He has left scap fracture on that side. So we have a number of things that are going to be painful with a cough. So placed a pillow under his arm, under his sling, chicken wing style, and discussed how splinting would work. Now, the difficult part with this one is that his left arm is painful to squeeze. So kept the pillow in that left side and had him use his right hand to hold the pillow as the splinting technique to allow him to actually provide pressure, because the left side was painful to hold even the pillow, but was comfortable to rest. So we went through education on splinting, positioning, just left the pillow right there while he was sitting up in the chair. And of course, what did we do for cough technique that is less painful? I taught him a huff cough. So he did great. He had fantastic technique. He was able to follow all the commands. He was able to get a good airy breath. He did it low in the beginning, less of an effort. He was able to get coached up to like a medium effort. He was pretty dry overall. So he doesn't have any active mucus yet, but now he has some strategies. If he does have to cough, if he has to sneeze for that matter, he has some things that he can do. One more piece of the Cardiopulm picture with this guy was his blood pressure. So he has a history of hypertension. He has not had his hypertensive meds since the day before. He was sitting pretty high at the start of our session. So he was at 180 over, I think he was low 90s, 180 over 92 is what I have here. So we're right at the top of, hypertensive urgency. Now, the reason why this might not be considered a crisis, a couple of reasons. Number one, they're aware that his blood pressure is high. Number two, he has not been appropriately medicated yet. Number three, he's had a big trauma episode and has increased pain. So the team was aware. Let them know during the session, actually. He was asymptomatic for the most part. And after transferring to the chair, he actually dropped by 10. So on paper, sometimes you might hear words like, oh, his numbers look better, right? But technically, it's an inappropriate response because he dropped by 10. It's not technically orthostatic hypotension, but it's an inappropriate decrease in blood pressure with activity. So after our session, I did one more reassessment just to make sure he wasn't continuing to drop and he was staying right at that 170 over, I think it was high 80s, low 90s on the last take. Still enough to be aware of. Now, a couple of things here. If he didn't have upper extremity involvement and he was fully weight bearing as tolerated, range of motion up tolerated, bilateral upper extremities, and we're actually going to be working on non-weight bearing gait, it is super important to have that in mind because the aerobic capacity that it takes to maintain non-weight bearing is very high. It is a high aerobic load, and it will increase blood pressure, heart rate, all of the things, especially if you have a history and now we throw trauma, pain, everything else on top of that, you can have an over exaggerated response. So, just another plug, take vitals, pay attention to them, get a starting number, because if you don't get a starting number, you don't have anything to refer back to. You have no sense of where was it, right? So if we just took the blood pressure in the chair and it was 170 over 80s, what does that tell us? It doesn't tell us a lot besides that it's elevated. The fact that he was higher than that and then dropped now says that he had a hypotensive response with activity and that he was near hypertensive urgency numbers. It's important. It's important to track it. So the reason why I said he was not fully symptomatic, he wasn't dizzy, but he did have a headache. He had a headache throughout the session. So he is hypertensive. He has a headache. Technically, that could be a symptom, but he just had a pretty traumatic crash that could also be, the cause of the headache. So there are multiple layers to this thing. What's really important for me, and I think part of the reason why I even started this podcast, is that we have to be able to feel empowered to utilize our skills, right? I've talked about the stereotypes in acute care. I've seen the stereotypes in acute care. I do not want to do just the minimum. I want to use my license, and I think it's important for us to continue to push and use our license to our full extent. My only job in the hospital is not to get someone to the chair or to ambulate someone. My job is to assess this person physically, to then potentially rehabilitate them to get them to the next level of care. My job is to help this person optimize their overall potential, not just to. So this person is a great example where you can say ortho trauma, and stick to orthopedic MSK type stuff. Yes, there's a ton of it. But there's also a lot of cardiopulm here. And I think it's important to address it. I think it's important to give your patient strategies. And those things are going to make a difference for your person. Even while we were transferring, there was education on using breath control to help with pain control in order to do that transfer successfully. So he did wonderful. He was an awesome sport. He was able to mobilize really well. He was down for all of the breathing exercises and assessment techniques. And he did better overall after. He was very appreciative to that. And it made a big difference, right? Because that lung laceration, that hemopneumothorax, those rib fractures, they're going to take time too. And they're part of this picture, and it cannot be overlooked. Assess, auscultate, teach breathing exercise, use your hands-on skills, teach them how to splint, be a part of that process, because that's going to maximize this person's potential. We needed more clearance on his left scap, but there are a ton more things that we can do in the world of range of motion, paired breathing, segmental breathing posteriorly. But the first day wasn't the day to do that. We definitely needed more information on the orthopedic side in order to address the cardiopulm side and to further progress mobility, right? So many cool things there. One more thing, road rash. If he has road rash on his ribs, his back, his chest, that healing process is also going to affect his breathing. It's just like a burn, right? Keeping pliability of that skin is going to help the long-term picture. Giving strategies to handle pain is going to help the long-term picture. Giving strategies to discourage atelectasis is going to help the overall picture. So assess, chest wall mobility, auscultate, teach the things that you know to maximize your person's overall potential, not just mobility. All right, that's all I have for you today. I hope that was helpful. I hope you got something out of this. If you have any questions, please reach out to me. If you learned something new or just enjoyed this podcast, drop me some stars, write a great review. It is 100% appreciated. I hope you all have a wonderful day, and whatever you have to do, get after it.